Meeting to order. Welcome to meeting number 82 of the House of Commons Standing Committee on Health. Today's meeting is taking place in a hybrid format pursuant to the standing orders. I'd like to make a few comments for the benefit of witnesses and members. Please wait until I recognize you by name before speaking. For those participating by video conference, click on the microphone icon to activate your mic, and please mute yourself when you're not speaking. Interpretation for those on Zoom, you have the choice at the bottom of your screen of either floor, English, or French. And of course, for those in the room, you can use your earpiece and select the desired channel. A reminder that all comments should be addressed through the chair, that would be me. Additionally, screenshots or taking photos of your screen is not permitted. In accordance with our routine motion, I'm informing the committee that all remote participants have completed the required connection test in advance of the meeting. Bill C-293, pursuant to the order of reference of Wednesday, February 8th, 2023, the committee is resuming its study of Bill C-293, an act respecting pandemic prevention and preparedness. I would like to welcome our panel of witnesses. Appearing as individuals, Dr. Lisa Barrett, physician researcher by video conference, Patrick Taillon, a professor and Associate Director of the Center for Constitutional Administrative Law Studies, Faculty of Law, University of Laval, by video conference. Representing the Canadian Medical Association, Dr. Kathleen Ross, President, by video conference. Representing World Animal Protection, Melissa Matlow, Campaign Director, and Michelle Amar, Wildlife Campaign Manager. Thank you for taking the time to appear today, and you will each have up to 5 minutes for your opening statement. The order we will use will be Dr. Barrett, Mr. Taillon, Dr. Ross, and I'm unsure if you could clarify, will Ms. Matlow, you will do the entire 5 minutes? Very well. And just as a reminder, I will remind you when you have 1 minute left. We're going to keep to a schedule here this evening. So, that being said, thank you all for being here, and let's get the show on the road, and we'll start with Dr. Barrett. Thank you.
Good evening, and thank you to the chair and to the committee for the opportunity to speak this evening, and thank you to all of you for doing after-hours work. I recognize that it's not early there. I'm an infectious diseases doctor, but also clinician researcher who does research in viral immunology, as well as the implementation of health systems related to infectious diseases. And my involvement throughout this most recent pandemic, I think, is my primary reason for being here. And I was involved at both the municipal, provincial, and federal levels in the domains of testing and innovative generation of ways to test people for infectious diseases, particularly COVID, as well as I was involved with and continue to be involved with therapeutics for COVID and the delivery and different models of delivery within Nova Scotia and different provinces. And so my view on the pandemic comes from there and all the biases and important information that may come. After reviewing the bill as it stands at the moment, I'll divide my comments very quickly into 3 different sections, that being the preparedness part, what we do and what we can do best in a pandemic, and then the post part I won't highlight as much. So to start with the pre-pandemic bit and predicting pandemics, I think one of the important parts that's mentioned within the bill at the moment is One Health, and recognizing that humans are a small part of the planet, while numerous, not the most important part when it comes to predicting pandemics and pandemic disease. And recognizing that there are other things that can cause pandemics and there are other threats, including antimicrobial resistance. Pandemics often are caused by viruses that spread through air. And I think one of the things we need to recognize more is that animal health is part of human health. We are one animal, and we can't forget about all the others. And that is noted in the bill, that there should be consideration around that area. But I think it's something we've done extraordinarily poorly, not just in Canada, but in the world, and should be a focus of the go-forward plan. Sticking with viruses and going into pandemic, I think it's important to note that there is an intersection again with pandemic potential pathogens. If you say that 3 times fast, pandemic potential pathogens and air. And that includes clean air of various kinds. And so while the respirologists have been saying for many years that we need indoor spaces that are clean, I think this has highlighted the fact that when we are at a density of where we are with human populations, not just in urban areas, but in rural areas these days, and the amount of time we spend indoors, that this has to be a priority of where we go forward is how we live in terms of cleanliness of air and what standards can be brought in to help that. And while that doesn't sound like a very infectious diseasey doctor thing to talk about, it is very, very linked to mitigation of spread when you're talking about a country with cold weather and a lot of people. And so the next part I would highlight that we could have done a better job with before and during this pandemic was understanding the patterns and pathogen disease and pathogenesis. So once we are into a situation where we have a pandemic, we really seem to get stuck many times in what the usual is and what the previous normal was, and an understanding of what respiratory viruses are. And clearly we don't understand that well, and I think we need to be very careful with any bill that comes forward that we highlight that. The third part, so that's research and understanding viruses, and also having a high standard for vaccine studies after they're marketed. There's a lot we don't understand about the variability of responses in humans. Some people respond well and some people don't. And we need to really hold to account companies and people that are doing vaccine marketing after the vaccines come to market, or we're not going to get far fast. And I'll hold the rest of my comments until later. Thank you for the opportunity.
Thank you very much, Dr. Baird. Appreciate that. Mr. Taillon, you have the floor for 5 minutes.
Bonjour, Monsieur.
Morning, Chair. First of all, I'd like to thank the members of the committee for this invitation to appear before you on Bill C-293. So without further ado, I would like to raise 3 criticisms about this bill. It's a bill that in several ways is unnecessary, and in some ways it actually deviates us from the real problem. And thirdly, it is not in keeping with the principles of federalism and shared jurisdiction with provinces in the health area. This bill is unnecessary because it aims to organize some sort of preemptive bureaucracy, and the cabinet and senior civil servants of the public service already have full latitude to assess, to project, to anticipate. This is already part of their role. They do not require a law to think about the next crisis. That's part of their job description. And then it also takes our attention away from the real problem, which is the need to come up with a record of the federal action during the last pandemic. So we're trying to look into all aspects, even aspects that are not within federal jurisdiction, rather than concentrating on the real issues. Why was the federal government so slow in taking up its responsibilities during the COVID crisis? Why the border controls? Why are why is it part of our responsibility? Why the action in terms of quarantines at the border was so slow to implement? Cities such as Montreal had to compensate for deficiencies from the federal government. Why were the Atlantic provinces forced to create boundaries or borders within Canada to compensate for lack of federal measures? And why this hesitancy to come up with the rules to manage the crisis? Why were there so many delays at the end of the crisis in terms of withdrawing or lifting the measures? On 2 or 3 occasions, they were late to act. So this will to coordinate, manage, control everything that's part of the bill is not good. It deprives the federal government and its administration of a critical review of its own measures. And especially this bill is not in keeping with federalism and federal and provincial jurisdiction in health care matters. This bill is the idea that everything will be better managed with coordination from above. We see this tendency to standardize everything, and it's as we see in Article 2, subparagraph 2, we say we have to arrange with the provinces to harmonize everything. When you say harmonize, you're talking about all thinking about the same way. It's a euphemism for saying we're trying to standardize everything. And it's taking away some of the initiatives of the freedom of action on the ground. And there are provinces that have done well, and then they were copied by others. If we centralize everything, it means during the next healthcare crisis, some of the errors we will make from above, everything will be reflected across Canada. And this is not in keeping with the spirit of independence and freedom that is involved in federalism. And also in the same article, we are talking about collecting and using data on a common basis. Once again, this is another euphemism which talks about accountability. We require provinces to come up with information, even in areas where they have jurisdiction. So in ending, we should not be naive. Either the prevention and coordination work proposed in the bill is not really decisional, or it means we don't really need that because the administration has the full freedom to carry out these activities, or maybe inversely we're trying to come up with new powers to coordinate everything, work with provinces, and in this situation we're in an area where in fact we are trying to change the nature of Canadian federalism, where the provinces have full jurisdiction in areas of health care. Thank you.
Mr. Taillon.
Thank you, Mr. Taillon.
Have Ms. Metlow for 5 minutes. You have the floor.
Thank you, Mr. Chair and committee members, for the invitation to testify on Bill C-293. I'm the campaign director at World Animal Protection. We're an international animal welfare charity with offices in 12 countries. We conduct a lot of research on the intersectionality of animal health and welfare, environmental sustainability, and human health. That research then informs our policy recommendations that we bring, and those intersections really are what One Health is all about. We have general consultative status with the United Nations. We have a formal working relationship with the World Organization of Animal Health, and we're members of the National Farm Animal Care Council. Joining with me today is Michelle Hammers, our wildlife campaign manager with an MSc in animal biology and co-author of the first published article on Canada's wildlife trade, specifically on the potential for disease risks and the lack of data and monitoring for it. You may be wondering why an animal welfare group wants to testify on this bill. 75% of new and emerging infectious diseases originate in animals, principally from wildlife. It is our mistreatment of animals and exploitation of nature that is driving the frequency and severity of diseases. And it's not just us that is saying that. It is repeatedly cited in various UN reports, like the report by the United Nations Environment Program on pandemics, or the report by IPBES on pandemics. Mpox, Ebola, SARS, MERS, West Nile virus, Nipah, Zika, COVID-19. It is widely acknowledged that a wildlife market played a significant role in the COVID-19 pandemic, whether it was originating in the origins of the virus or amplifying. These markets typically hold a variety of different animal species that wouldn't normally encounter each other in the wild. They are kept in crammed conditions, in stressful conditions, often in unsanitary conditions. These are called hotbeds for emerging diseases. When animals are stressed, they become more vulnerable to infections and they become more infectious. And that is why this is very much an animal welfare problem at the core. We strongly support this bill because it takes a One Health approach and puts emphasis on prevention. It identifies the top pandemic drivers and it requires government to address those drivers and mitigate those risks. So often, prevention is viewed as increasing surveillance and monitoring, but surveillance cannot detect asymptomatic animals who carry a disease, nor does it prevent pathogen mutation and emergence. Scientists have warned that we are entering a pandemic era. If we truly want to reverse course, we must include pre-outbreak measures to prevent spillover at the human-animal and environment interface. To quote from the IPBES report, without preventative strategies, pandemics will emerge more often, spread more rapidly, kill more people, and affect the global economy with more devastating impact than ever before. Tackling the root causes of spillover is a fraction of the cost of responding to a pandemic. One study found that halting deforestation and regulating the wildlife trade could cost as little as 2% of the economic cost of responding to the COVID-19 pandemic. It is also critically important that this bill mentions well-known pandemic drivers. These are already identified in the scientific literature by credible authorities and global agreements that Canada has committed to. These drivers include the illegal and under-regulated legal wildlife trade, which is growing in volume, live animal markets, intensive farming methods, and land use changes. These have been identified in, again, the UNEP report and the IPBES report, which I believe are available to you. The current draft of the World Health Organization's International Pandemic Instrument also mentions the need to address disease drivers, including but not limited to climate change, land use change, the wildlife trade, desertification, and antimicrobial resistance. Bill C-293 would help Canada fulfill its obligations to this new global agreement. The World Health Organization refers to the rise in antimicrobial resistance as the silent pandemic and one of the biggest public health concerns of the 21st century. This relates back to animal welfare because 3/4 of all antimicrobials used in Canada and around the world are given to farm animals. For decades, these preventative antibiotics are given in the absence of clinical disease to stop stressed animals from getting sick and facilitate intensive farming methods. Thank you for your time.
Thank you very much, Ms. Matlow. Sorry I didn't give you the 1 minute. I gave you the 30 seconds. I was hoping you were paying attention. Well done. Next, we'll hear from Dr. Ross. Dr. Ross, you have the floor.
Thank you, Chair. My name is Dr. Kathleen Ross, and I'm joining you from the traditional territories of the Indigenous people of Treaty 7 and the Métis Nation of Alberta Region 3. We acknowledge and respect the many First Nations, Métis and Inuit who have lived in and cared for these lands for generations. I am a family doctor working in British Columbia. As president of the Canadian Medical Association, I represent the voices of the country's physicians and medical learners, those they care for, and those who don't have access to care. As the committee studies Bill C-293, an act respecting pandemic prevention and preparedness, it's important to hear from those who have been on the front line since long before COVID-19. Already caring for patients in a broken system, each subsequent wave submerged health workers under deeper backlogs and even greater system impacts. Canada's response to COVID-19 must inform our plans for future pandemic preparedness and prevention strategies. Appropriate planning to support our health workforce at the outset remains critical to keeping Canada safe. The spirit of Bill C-293 is to improve the way we prepare for the next pandemic, and we welcome the proposed steps towards collaboration across jurisdictions and are pleased to see an emphasis towards building primary care capacity. The language that speaks to improving working conditions for essential workers and increasing the ability of healthcare workers to perform their duties in a scenario of increased demands is promising. But the stark truth is we must focus on alleviating the significant impact the pandemic continues to have on the health workforce today. Creating a safe, robust, and healthy workforce can't wait. The heroic efforts of our health workers continue, and we are at record high levels of burnout and exhaustion. My colleagues are demoralized and looking to exit the profession. We hope that the impact on health and wellness of health professions will be a big part of any review and an even bigger piece of planning. Rebuilding the trust of our health workers and Canadians is critical to pandemic preparedness. Chair, the announcement of increased health funding earlier this year was welcome. That spending must be targeted and invested in areas that truly bolster healthcare systems. Canadian physicians must be able to work where the needs are greatest. As an example, in April 2021, COVID-19 cases were surging in central Canada and many communities were pushed beyond their resources. A cadre of healthcare workers, including physicians from Newfoundland and Labrador, assembled quickly to help struggling communities 3,000 kilometers away. That deployment necessitated a swift and temporary lifting of the usual provincial licensing restrictions, allowing physicians to get an Ontario license within 1 week. Look at the potential of that model, a single licensing system implemented across the country to alleviate the pressure on medical workforces, serving patients in rural and remote communities, providing virtual care across provincial and territorial borders, providing more timely access. This is critical in preparing for future pandemics. Pan-Canadian licensure can be implemented across the country as provincial and territorial health ministers committed to last week in PEI. This is the time to deliver on our promise to increasing access to family doctors and primary care. Scaling up collaborative interprofessional care is central to increasing access and limiting the spread of future disease. Physicians are overwhelmed by unnecessary administration, a lack of interoperability, third-party and federal forms, and managing large volumes of data that are often incomplete. Admin burden amounts to 18.5 million hours per year, and those hours could be transferred to better patient care and physicians' own wellness, hours we cannot afford to lose in the surge of a pandemic. We must plan for what our health workforce may face. Gaps in the availability of timely health data is critical. We need to be able to harness data to contribute to the development of an integrated pan-Canadian health human resources plan. Data is necessary to understand the breadth of the myriad of healthcare challenges we face and to chart a sustainable course for the future. Without a transparent and accountable blueprint, we are unlikely to reach consensus on our destination. Chair, I thank you for the committee's time today, and I will welcome any questions the members of the committee might have.
Thank you very much, Dr. Ross, and thank you to all the witnesses. Clearly, my system was very, very effective. I just want to point that out to the members here, keeping folks on time. That was very good. Thank you all for that. Now, what we'll do is start rounds of questioning, and we'll start with Mr. Doherty. And Mr. Doherty, you have the floor for 6 minutes.
Thank you, Mr. Chair. Mr. Chair, I want to thank our witnesses for being here today. Mr. Chair, I've been in receipt of, and I think all of our members on this committee have been in receipt of a letter from 17 of Canada's leading addiction medicine physicians. And Mr. Chair, I know that you are in receipt also of the motion that or the clerk is, that we tabled on Monday. And with your permission, I'd like to table that motion now, Mr. Speaker, that given the recent letter from 17 experienced Canadian addiction medicine physicians to the Minister of Addictions and Mental Health, calling on the government to cease funding of the hydromorphone for people with addictions, that the committee recognize that A, the substantial increase in opioid-related harms and deaths, B, that the government's current policies are not working, C, that the so-called safer supply strategy is a failure, making the opioid crisis worse. I'd like to move this motion, Mr. Chair, that the committee call for an immediate end to the government's so-called safe supply funding, and that the committee report this motion to the House. Mr. Chair, I've been very public and very vocal and upfront about our family's own struggles with addictions, and how I have a brother that lives on the street, that we have struggled to get him off the street, that I have gone into the dens of evil to pay off his debts, to save my brother, to save somebody that we love. we have rescued him in the middle of the night from a bridge from gang members that were threatening to throw him over if he didn't pay the debt. 2 years ago, he was shot twice in a drug deal gone bad with a shotgun. And it was just mere days later, after saying all the right things, that the draw and the pull of these drugs got him back onto the street with buckshot and the wounds and the tubes kind of hanging out of him. Mr. Speaker, that's how strong these drugs are, the pull of these drugs are. And to my colleagues across the way, we have to do better. I get emotional talking about it. In 2016, there were 806 opioid deaths in BC. In 2016, that was in 2016, and in 2022, that is there's 2,410 to date. It is a leading cause of death for BC youth ages 10 to 18 is overdose. That surpasses accident. We have to do better. There are businesses in my province that are buying illicit drugs on the black market, and they are selling them or giving them away on the street. How far have we fallen that you can perpetuate somebody's addiction, but we can't get them into a bed for recovery? If you don't believe me, if my colleagues across the way don't believe me, believe the 17 leading experts in our nation on this, that write this. We are a group of experienced Canadian addiction medicine physicians who are calling on the government to ensure that all hydromorphone prescribed to people with addiction is provided in a supervised fashion, or that funding cease for this harmful practice. Calling unsupervised free government-funded hydromorphone safe supply or safer supply does not make this practice safe. It is unsafe. Hydromorphone is a potent opioid which is approximately 4 times more powerful than morphine when taken orally, and approximately 7 times more powerful than morphine when injected. Hydromorphone and other drugs are often prescribed for safe supply at 7 to 10 times the maximum recommended morphine equivalents per day, and poses serious risks to the patient and their communities from diversion. Unsupervised free government-funded hydromorphone provided to people with addiction is causing further harm to our communities by increasing the total amount of opioids on the streets and providing essentially unlimited amounts of opioids to vulnerable people with addiction. As a result of this practice, we are witnessing new patients suffering from opioid addiction and additional unnecessary overdoses and death. The FDA product monograph for Bilaudid hydromorphone states this: acquire more fentanyl, paradoxically unsupervised free government, misuse, abuse, and diversion of opioids. Hydromorphone is an opioid agonist of the morphine type. Such drugs are sought by the drug abusers and people with addiction disorders and are subject to criminal diversion. Dilaudid can be abused in a manner similar to other opioid agonists, legal or illicit. This should be considered when prescribing or dispensing Dilaudid in situations where the physician and pharmacist is concerned about an increased risk of misuse, abuse, and diversion. Dilaudid has been reported as being abused by crushing, chewing, snorting, and injecting the dissolved product. These practices pose a significant risk to the abuser that could result in overdose or death. Unsupervised free government-funded hydromorphone provides a significant source of income to people with addiction who divert their prescribed hydromorphone to the street market. There's widespread evidence that this is occurring. The money from diversion is commonly used to purchase more potent opioids such as fentanyl. While we understand the desire to minimize the morbidity and the mortality resulting from illicit fentanyl use, unlimited overprescribing of opioids is causing harm. Increased availability of opioids in communities leads to more opioid addiction. The unmonitored provision of free government-funded hydromorphone to people addicted to opioids has become widespread in a large part because of government funding and support. Unfortunately, this unsafe practice has become politicized in both government and the medical field, causing harm to both the public and patients suffering from opioid addiction. The risks of unsupervised free government-funded hydromorphone prescribing include this. People with addiction commonly prefer to inject hydromorphone. Injected hydromorphone creates a similar elevated risk of serious infections that all users of intravenous substances face, such as Hep C, HIV, cellulitis, bacterial endocarditis, respiratory suppression, overdose, and death. A large supply of free hydromorphone can make people's addiction worse and delay people from entering other treatment modalities which have been proven to be effective. Diversion of prescribed hydromorphone to the illicit market is the most significant problem. With unsupervised, free, government-funded hydromorphone tablets are sold and the funds are used to acquire more fentanyl. Paradoxically, unsupervised, free, government-funded hydromorphone increases access to street fentanyl for people with addiction and also increases the availability of street hydromorphone, causing more people to become addicted to opioids. We anticipate the widespread diversion of hydromorphone now taking place from these programs will have results similar to our experience with OxyContin epidemic with OxyContin. We saw how the provision of abundant amounts of powerful opioid to communities made addiction worse for those with disease, and more importantly, it caused many new cases of opioid addiction. Mr. Speaker, I can see my colleague from the Liberal side that's laughing while I'm struggling to read this letter. I'm struggling. Perhaps Mr. Fisher doesn't have people that have been inflicted with addiction, that perhaps he hasn't sat with parents of those that have passed away due to overdose. I'll continue. The final quote of this letter is this: "Safe supply is a nice marketing slogan. The reality is it's not safe. It is harmful to give people addicted to opioids almost unlimited access to free opioids. It is harmful to our communities for inexpensive pharmaceutical-grade opioids to be flooding our streets. We call on the government to ensure that all hydromorphone prescribed to people with opioid addiction is provided in a supervised fashion, or that funding be ceased altogether for the current harmful practice. Stop diverted hydromorphone from creating more children with addiction in our junior high and high schools." Mr. Speaker, Mr. Chair, I read this in, and it's obviously something that is we are gripped in an opioid crisis in our country. Canada.ca, our own government website, under the heading Responding to Canada's Opioid Overdose Crisis, our government's own words, Canada is facing a national opioid overdose crisis that continues to have devastating impacts on our communities and families. And yet we are sending taxpayer dollars to organizations that are buying illicit drugs, black market drugs. that are flooding our streets and our communities. And we're powerless to stop this. Somebody has to answer to this. You can laugh. You're not laughing now,
Mr. Chair, point of order.
but you did earlier, Mr. Fisher. You did. When you shouted across the way.
Mr. Chair,
You know,
this is a
Mr. Chair, it's still
reputational
my
comment
floor.
when someone makes this a
It's still
comment
my
like
floor.
that.
Excuse me, before this deteriorates, remember, we have to be recognized by the chair, please. And I would really appreciate, Mr. Fisher, for you to respect those rules. I know you're new to our committee here, but please, before you begin speaking, the person who has the floor has it. When I recognize it, recognize you, you too shall have your turn to speak. We all heard very clearly from the speaker today about decorum. And if your point is relevant, terrific. If not, perhaps we should continue on.
Point of
I-
order, Mr. Chair.
I
Yes,
apologize.
please, Mr. Fisher.
Thank you, Mr. Chair, and apologies. I would never, ever laugh at a topic this serious. I looked
appreciate
at the
that.
witnesses, I smiled and said, I'm sorry to the witnesses. That's what I did, Mr. Chair. Thank you very much.
Very good. Thank you. Thank you for clarifying that, Mr. Fisher. And I will echo those comments that sorry to the witnesses. Obviously, this is committee business that is not related to Bill C-293. I guess I am absolutely unsure as to how long this may take. I would ask my honorable colleagues to consider thinking about releasing the witnesses. This may take some time, I would suggest. I'm not suggesting I'm at the will of the committee, but I guess I would suggest to my honorable colleagues, if that is your desire to release the witnesses and apologize to them, then we'd absolutely happy to do that. I'll leave it at the will of the committee.
I still have the floor.
Mr. Doherty, you have the floor.
I'll apologize. Apologize to Mr. Fisher. I did see him look across the floor and say, "Hi, Dan," mockingly. I thought mockingly. I could be wrong. Maybe he's just acknowledging the presence of our colleague from the NDP. You know, we live every day with the fact that we're going to get a call one day that my brother won't be around, that he'll take one last dose. Let me bring you back to the 2008. When I was loading my bags into my vehicle to go speak at an event in overseas. And my wife opened the doors to our front doors to our house, and with tears, she said that her brother had been found dead from an overdose. He was not an addict. He didn't use drugs. He simply was in the wrong place at the wrong time, and somebody gave him something that was laced with fentanyl. That same person wiped his phone. So there is no evidence of who was there at the time. We don't know. So I apologize for this emotional motion, moving it. But it hits home. And given being the shadow minister for mental health and addictions or suicide prevention, I sit with so many families that asks us to do something. I don't have the answers, but I don't believe that we should be funding this money, taxpayers' dollars should be going to fund these drugs. We should be doing everything in our power to make sure that we can get somebody into a bed for recovery. Recovery is always possible. Perpetuating somebody's addiction. You know, in British Columbia, I believe it's 18 to 24 months. That's what one mother came to me. She said, why? Why is it that my son can get drugs, but I can't get him into treatment? If I was wealthy or rich, they could do that. But these people, a lot of these people come from families that can't afford treatment. So 18 to 24 months. If her son is still alive, and we know what they're doing is they're taking these drugs and they're selling them so that they can purchase. And oftentimes they're taking them and they're selling them to students so that they can take these drugs or they can purchase the higher doses of fentanyl. We've got to do something. I apologize to our the witnesses. But after reading that letter, I had to say what I said. I've stood in the House so many times and talked about this. And this government and my provincial government, we as leaders are failing Canadians when it comes to this. And we have to be better. I'll cede the floor to whoever's next. Thanks.
Thank you very much, Mr. Doherty. I do have a speakers list. It reads Dr. Kitchen, Mr. Majumdar, Mr. Fisher, Mr. Davies, Dr. Pawlowski, Mr. Theriault. Dr. Kitchen, you have the floor.
Thank you, Mr. Chair, and my colleague, my thoughts
Point d'ordre,
with
Monsieur
you.
le Président. Point d'ordre.
Point of order, Mr. Chair. I see the list of interveners that asked for the floor. I see our witnesses here, and they are taking part in this discussion. Whereas we invited them here for some other purpose. Maybe I would just want to relax the atmosphere a little bit. Mr. Taillon, when you said this bill was unnecessary, I didn't think it would be so convincing in the long run. But that said, I think we should let the witnesses go.
Merci beaucoup, Mr. Theriault.
Thank you, Mr. Theriault.
You know, certainly I'm at the service of the committee if that's what committee members would like to do. I have no power to do so on my own, but certainly if members would like to do that, I'm certainly happy to hear that. Perhaps by consensus, is that the will of the committee that we will release the witnesses?
Mr. Chair, if I might just ask before I can cast an informed vote, is it Mr. Doherty, the Conservatives' intention to talk the entire meeting about this issue? If it is, then we should let the witnesses go.
Very
But if
good.
not-
Thank you for your interest, Mr. Davies. I don't think we'll be going back and forth in that fashion. My question then is back to the committee. I think it's a wise one that Mr. Theriault has brought forward. Is it the will of the committee to release the witnesses? And if not, we shall continue with the speakers list. We have release.
I vote no, but
Okay, if we suspend. We'll suspend for 2 minutes. Again, so what the committee has been tasked with is understanding whether they wish to dismiss the witnesses or not. As I said, I'm serving at the will of the committee. It seems as though that certainly the Conservative members were willing to dismiss the witnesses. Monsieur Thériault, unsure at this time. Liberal members, Mr. Fisher.
Thank you, Mr. Chair. Is there a possibility that we could keep the witnesses for an hour, have a good conversation with the witnesses for an hour and ask some questions, and then resume this conversation after that for the last 30 minutes of the meeting?
Well, I would suggest to you that that would not be the regular convention, that this motion is now, of course, the subject of the committee at the current time. So I will redirect the question that I had. Shall we dismiss the witnesses or not? Is it the will of the committee? Nope. Okay, very good. Thank you for that. Appreciate it. Dr. Kitchen, you have the floor.
Thank you, Mr. Chair. And as I said earlier, my thoughts are with my colleague and how important this topic is to him and his family and the huge impact that it's had on his life. And it's a prime example of that. His motion that he's put forward is one that addresses this aspect of things, and something that is being addressed from a very, which should be addressed in a very rapid way. And it's not like this hasn't been going on for centuries. It has, but when we look at statistically, and for example, I will speak from a Saskatchewan point of view, and when we look at 2022 last year, We had 421 reported opioid deaths in the province of Saskatchewan last year. And then in the 4 months that we've had so far in 2023, the province has already had close to 200. These are huge numbers that are just escalating because of what we're seeing around the country, and some of it is related to the price of the product has become more easily accessible when we have parts of the country that do have safe havens for this, and so the drug prices have dropped to almost $2 in many cases, which makes it even easier for vulnerable people to use this. We look at in small communities, and my riding, Souris Moose Mountain is 43,000 square kilometers in size. But with that said, in Saskatchewan, 47 small communities in Saskatchewan, and most of them in rural areas, have had confirmed overdoses. And in fact, in one of my small towns within my riding, and I'm very well aware of the challenges that have been there. And it's disgusting to hear and see some of the things that are going on. I had a constituent who approached me on the issue and how she basically said in her community, they know where the drug house is. They know where it is. They've told the RCMP this is where it is. They've asked the RCMP to go in, and the RCMP have basically said, no, we're not going into that place because of how dangerous it is. So this lady took it upon herself, and I can tell you this because she gave me permission to tell you this story, is she went into this house on her own. She went in there to confront what was going on and saw a lot of the things that were going on, to the point where she was saying this is inappropriate. And there were these big people that were carrying all sorts of weapons, etc., that she confronted, and to the point where she went from room to room, and she went into one room where there was a 13-year-old girl that was being molested during this drug infestation that was going on. And she went into this room and tried to bring this young girl out of that room, and to which the drug lords that were there confronted her at that point in time and basically threatened her with her life to get out, or she would not be safe. And this transpires in a small community in Saskatchewan. Now, it's going all over this country, and it is despicable that these people are doing this and taking advantage of vulnerable people in many ways. We look at Saskatchewan, and so as I indicated, that there are 291 humans have died from unregulated drug overdoses in January to June of 2023. Motor vehicle accidents in Saskatchewan resulted in only 87 deaths in the province. Motor vehicle accidents have fewer deaths than those from drug overdoses. That's just shocking, and we know how passionate we get when we hear about motor vehicle accidents, from whether it might be someone that's impaired or just an accident where someone had a head-on collision. This is just unbelievable that we are seeing even more from what we're seeing this happening around this country. It's a major factor when we look at things in Saskatchewan, and the life expectancy in our province has dropped since 1999. The average life expectancy was 78.48 years, and it's now down to 76.5 for men alone because of the deaths from drug overdoses. These experts attribute this drop in the deaths among younger people from the drug and suicide, and where we see there's been a 300% increase in drug toxicity deaths since 2010. That's just unbelievable. That's 14 years ago. Now, many of you may know my history and some don't, but I spent my life traveling all over the world when I was a youngster, and I traveled, my father being a military attaché, and we drove from Germany to Pakistan and back, and we lived in Pakistan, Afghanistan, and Iran for 3 years of our life. And I remember my time in Afghanistan, and that is where, in Afghanistan, Pakistan, and that Silk Highway is where a lot of these drugs are found. You know, the poppy plant, which is basically the Papaver somniferum, which is the poppy plant, is grown quite extensively throughout Afghanistan. And if anyone ever wants to come up to my office, they're more than welcome, because I have pictures of these poppy fields when I was a teenager in those days, and seeing these poppy fields, which, you know, everyone thinks about the red poppy, but it transitions from many different colors. But the reality is that poppy plant is basically creates morphine, it creates codeine, it creates heroin, it creates oxycodone. And so there are so many different substances that are out there that you see where people are, they smoke it, they'll sniff it, they'll inject it. And my time when I was as a teenager, when I was traveling through that part of the world, I saw the consequences of many of the local constituents who utilized that product. And that was, as I say, that's going back to 73, and you go back, go back centuries. It's been going on forever. But now we're seeing it here in Canada, and we're seeing it around the world, but more so for us as we talk as parliamentarians about the huge impact that it's having on our families, on our friends, on our constituents. And this huge impact is to this addictive substance, and that's what it is. It initially was designed for, when we look at it and speaking from a healthcare point of view, for the value it was as an anesthetic, and a value it was used in providing pain relief and assistance. But ultimately, it's been taken one step forward, and it continues to be taken one step forward, because we see continuously these safe houses that are opening up around this country, which is opening it up for more use and increased usage of these products. And God forbid that any of us, and as my colleague has talked about, how that impacts you personally, and you see that, and you see the impact it has on your family. On the impact on the lady I spoke to you just earlier about in my community, and what she saw. I've had other constituents who have come to me and phoned me and talked about how their son has become addicted, and they try to do steps to do things to release them from that addiction. And the challenges that they have is because their son is over 18 years of age, and because of that, the son basically gets put into a center where he dries out for 2 or 3 days, and then when he comes back out, he's back into the same area, and he gets addicted because there's no programs to protect these people and to assist them in becoming such that they aren't addicted to these products. And that's a huge impact when we see that. And this lady who was telling me about her son, basically, she's fearful for her life, because when he gets out, and he gets out released from jail, because the police will catch him when he breaks into some place to get some money so he can purchase some of these drugs, they release him. And the moment he's out, she's fearful, because he comes and he threatens her husband. He comes to the house, he threatens to burn it down. And so she has all these fears that she has to deal with, and it's so unfortunate. And I can't imagine as a parent how I would deal with it personally, if it was one of my own immediate family, or even my relatives, in how impactful it can be. So this motion that my colleague has put forward, it's one that I think we need to act on as quickly as possible. It needs to be addressed. And I apologize to the witnesses for this, but I think it's such an urgent nature that we need to get this brought forward, and we need to address this issue as quick as we can. So I wish my colleagues around the table would see the urgency for this and be very supportive on allowing us to get this done and brought forward so that we can do the right steps so that we can address this issue and get it addressed as quickly as possible. With that, Mr. Chair, I will cede the floor.
Thank you very much, Dr. Kitchen. Mr. Majumdar, you have the floor.
Thank you, Chair. You know, I was listening to
Point of order, Mr. Chair. It's interesting to me that you recognize 3 Conservatives in a row. I had my hand up very early on.
Thank you very much, Mr. Davies.
Well,
those are the people who had their hand up first. Thank you. Mr. Majumdar, you have the floor.
That's quite ironic.
I understand the reluctance of the NDP to talk about the opioid crisis, given how much they've had a hand in facilitating it through their safe supply policies in this country. I was thinking as I was listening to my colleague, Mr. Doherty's family experience in this, there's a lot of us around the table who have virtue signaled around the question of an opioid crisis for quite some time now. And here we are at the Standing Committee on Public Health, of which I am a rookie, a newcomer. And I would imagine that we would be exercised by the defining issues that Canadians are being confronted by, particularly the most vulnerable Canadians. And in the aftermath, I mean, the PMB that we were looking at described, pretends to be a review of the lockdowns, but the lockdowns, the COVID policies, the pandemic policies that we have been dealing with, which the witnesses are here to inform a little bit, have had massive effect, have had massive impact on the mental health of Canadians. Thousands of people lost their livelihoods as a result of terrible COVID policies, who have in turn turned to drugs, and a federal government ready to offer up the solution with the safe supply of opioids. This Liberal NDP coalition is obsessed with a culture of death through their policies on medical assistance in dying and safe supply. And it requires leaders of conviction to step forward to confront it here at this committee, in Parliament, and around the country. So, Mr. Doherty, I'm grateful for your courage in tabling this motion and moving this motion. And I encourage all members of this committee to pay close heed to it. A couple of reflections from my own home province of Alberta. 7,000 Albertans have died of opiate poisoning between 2016 and 2022. 7,000 people.
And those numbers are actually probably higher.
The numbers, as Mr. Doherty notes, are probably higher. This is what we know. The Alberta government and civil society has been informed by an amazing organization that is led by an individual in my riding. His name is Dr. Vose, and his recovery-oriented model for victims of opioid crises is a force of nature. It is a holistic approach on patients, their families, and has returned 70% success with victims of opioid addiction. And this Alberta recovery-oriented system of care is something that, in our great federation, we can examine closely as a model that could be replicated everywhere. Their capacity is only about 23 patients at a time, 23 patients and their families. And when you think about the scale of what I just described, with 7,000 people having died already, it's a scaling that cannot come urgently enough. Replicated properly will take a year or two to even get teams of people deployed in places around the country. And, in London, Ontario, because of the safe supply policies of the Liberal NDP coalition, the price of hydromorphines have gone from $20 to $2. They're flooding the market and killing Canadians. And it requires us to really examine this issue with the kind of gravity it deserves so that we can bring home our loved ones drug-free. So, Mr. Chair, I want to thank Mr. Doherty for raising these issues, for the opportunity to reflect not just what we're seeing in Calgary, the price that we've experienced in Alberta, and I encourage members of this committee to take this as seriously as a heart attack and elevate it to the place that it deserves in the consideration of our public life and in our parliament. Thank you very much.
Thank you very much, Mr. Majumdar. Mr. Fisher, you have the floor.
Thank you very much, Mr. Chair, and this is an incredibly important topic to talk about. As a committee, we're tasked with legislation, and the legislation we are tasked with tonight on a tight timeline is C-293. Dr. Ross said it's important to hear from people from the front line, and Dr. Barrett, who's famous for saying health without knowledge doesn't happen. With the respect for our witnesses, I move to adjourn debate.
Thank you very much, Mr. Fisher. As we all know, this is a dilatory motion, which will, of course, mean that we will not have a debate on this, and we will have a vote immediately. All those in favor of the motion? 1, 2, 3, 4, 5, 6, 7, 8. In favor of our motion. Sorry, no. In favor of Mr. Fisher's motion. 7. All those opposed? 3. Therefore, we will adjourn debate as per Mr. Fisher's request. I need to confer with the clerk for 30 seconds, please. Thank you very much, colleagues. Ms. Sidhu, you have the floor. Excuse me, Mr. Doherty. So I've conferred with the clerk, and I think we've had this convention here before with the other chair that when we move a motion, it's our turn for 6 minutes, whoever that turn is, that we have considered that that is using that time, and therefore we'll move on to Ms. Sidhu for 6 minutes. Thank you.
Thank you, Mr. Chair. Thank you, all the witnesses, for your patience and for being with us. So I will ask for my first questions to Dr. Ross. Dr. Ross, I want to recognize the importance of your organization and knowledge you gathered through the pandemic. And my question is that, earlier this month, Mr. Holland spoke about the importance of data sharing during the meeting of Health Minister. What is the role of reliable and accessible data system for both health systems and patients? Can you talk about that?
Through the chair, yes, I'd be happy to speak about that. So there were several challenges that we faced across the country with regards to data. I'll speak first about data with regards to our health workforce. We lack a standardized national database of healthcare workers in this country with specifics around what are they qualified to do, where are they working, and what is their area of expertise. This is something, if we're going to have a pan-Canadian health workforce strategy, we need to begin with the basics of knowing who's doing what, where, when, and under what circumstances to build forward. The second has to do with a lack of consistent health data collection. And we know across jurisdictions in Canada that health data is collected in varying forms. And that has proved challenging to share data across jurisdictions for that reason. If we are going to be prepared moving forward to preparing for the next pandemic or next health crisis, then I think it behooves us to actually have a database that we can access to know who's doing what, where in our workforce, as I said, but actually also have an understanding where are the gaps in our health and when are we able to implement strategies to improve health. If I was to look backwards in time, and I'm sorry, I don't want to take too much of your 6 minutes, but there are definitely some public health lessons that we learned from the COVID-19 pandemic. And that had to do with funding of our public health teams and organization, defining or increasing awareness of our public health physicians and public health practices and service delivery. Certainly managing our health system, so prioritizing a sustainable investment in staffing capacity, acknowledging and addressing the significant burnout among healthcare workers and public health. Investing in and developing public health information systems is critical. Decision-making, prioritizing community engagement, looking at a focus of improving health promotion and prevention, and certainly modernizing communications and training and strategies. All of this requires a solid foundation in data and shared data.
Question is to Dr. Barrett. Dr. Barrett, could you speak to the process of the early detection systems like wastewater monitoring to inform public health decision for managing the present pandemic to future one, how we can see from the wastewater monitoring? Dr. Ross or Dr. Barrett, if you can comment on that.
I can start, and maybe Dr. Ross, if she wants to chime in. So I think the part of the bill that would be most relevant to what you speak of in terms of early detection, so clearly there's a need for early detection, and clearly we weren't doing it well. Wastewater is a technology that became more used, probably for the first time globally, through technologic innovation and need. And that became very apparent very quickly. It was not quickly and uniformly, I would say, adopted, and that's still the case. And this also speaks to part of the purpose of a bill such as this is to take things that can be useful and not require them to be used, but to collect the data and where places want to use that information to be able to. So 2 bits there. 1, innovation that quickly comes to pragmatic use. 2, standardization of collection of data that can then be used in different provinces, even in slightly different ways to respect federalism and then the associated provincial jurisdiction. But also then 3, it comes back to the idea on a bigger scale that things that are in a research domain have to quickly become used and tested in a practical way, quickly, without bureaucratic restriction. And in the pandemic preparedness world, the parts of this bill would actually be useful in doing that.
Thank you. Quickly, how we can combat the misinformation, disinformation? We all know the COVID-19 vaccine is very effective. Just quickly, if you can comment on that.
Is that for me, for myself?
Yes, Dr. Barrett.
Yeah, I think this comes back to trust. And understanding that we have to be respectful and mindful of both individual decision-making and population-based messaging. People are smart. We need to respect that. And where there's a need for education, combine that with science. That comes back to trust. Withholding information and parsing it is not a useful tool in a public health emergency.
Thank you very
Chair,
much,
if I
Dr.
can add on
Barrett.
to that.
Thank you very much, Ms. Sidhu. I'm sorry, Dr. Ross. You'll have to try another time. That's the end of Ms. Sidhu's round. Michel Thériault, vous avez la parole pour 6 minutes.
Mr. Thériault, you have the floor for 6 minutes. Thank you. Thank you, Chair. I would like to thank the witnesses for your patience. And I'm sorry about this parenthesis, not because the issue is not really important, but customarily, I can assure you that in the Health Care Committee, when we invite witnesses, we have at least 1 round of questioning before moving to another topic if it's significant enough. So we will do that, but I do want to apologize. This is not our normal process. I thought the motion will be tabled after the first round of questioning. That said, Mr. Taillon, I think we have lost the essence of your testimony, but you said, first of all, that it's an unnecessary bill because you're wondering if it really requires a law to implement an action plan. And what about, should we then believe that the authorities involved currently are not working on a plan to address some of the shortcomings during the pandemic. Was that what you said? Did I understand you clearly? Yes, if the bill is only aimed at planning, discussions, these are already powers that the federal bureaucracy has, so there wasn't any really need to legislate. This is already possible. So if you want to give some coercive powers to the administration to push things through, that's what's happening in terms of harmonizing with the provinces or trying to standardize everything. I think we're investing our energy in the wrong place. When I heard Dr. Ross talk about training for healthcare personnel, this is done during the education process. That's within federal jurisdiction. So normally the federal jurisdiction will not have that information. The professional orders, who can be a doctor, who can be a nurse, that is all within provincial jurisdiction, and also hospital management. So the next crisis might be the opioid crisis, maybe an environmental crisis. The essence is people should take full charge of their areas of responsibility. We have challenges managing our borders during the pandemic. That wasn't always smooth. Managing the vaccinations, that wasn't always smooth. So this bill should not be an excuse to not look into how Ottawa exercised their jurisdiction. It's like when you're in school, you had good students, poor students. So the weakest student in the class is trying to show how to learn to the other students. That's not how it works. People should stay within their lanes, and Ottawa does have lessons to draw after the last pandemic as far as their jurisdiction to better exercise their powers instead of trying to harmonize and control what is not really within their jurisdiction. In your testimony, something struck me when you said that there was a risk of of trying to centralize everything, because when we do make a mistake, it's reflected all over from one part of the country to the other. So the stakes with this pandemic, I think we were able to cope relatively well. People were able to live through different health protection measures from one part of the country to the other. That's because there is a duty to ensure coordination. But the efficiency it really resides within decentralized coordination. Even in Quebec, in some of the sanitary measures, that's my view of the pandemic. I was sitting on the healthcare committee. Quebec was taking care of that. I think Quebec was the first province to declare a health state of emergency, and the federal government wanted to support the rest of the world. That's how we saw this. And within Quebec, we wanted to apply different measures when we noticed at one point that we had to get out of the quarantining, and all of a sudden the vaccines came faster than expected. So I would like to hear, maybe just for a minute, yes, that's because this management that is as close to the citizens as possible, it's a more human model, and it's a way of having good competition. If some good ideas come up in British Columbia, Quebec is inspired. Or in Alberta, people copy good practices, and in the long run, everyone wins, because facing a major challenge such as we did during the pandemic, we must allow some local innovation instead of trying to coordinate everything from afar at different levels of government, whereas we know the information is not always available because health care is not within federal jurisdiction, except for health for the military, for the indigenous populations. there is a lot of work to be done in those areas, and I think that that's where the federal government should invest their efforts. Thank you, Mr. Tayoung. Thank you, Mr. Theriault.
For 6 minutes.
Thank you. Dr. Ross, a recent series from the British Medical Journal found that Canada's emergency response during COVID-19 was, quote, impaired by long-standing weaknesses in the public health and healthcare systems, including fragmented health leadership across the federal, provincial, and territorial governments, end quote. Do you agree with that finding?
The fact that we know the pandemic exacerbated our pre-existing fragmented and broken healthcare system is highlighted in that article. The pandemic raised awareness of the chronic gaps that we have in our healthcare system and that we continue to experience, but the pandemic itself did not cause it. This particular legislation certainly could help us identify what we could do to be better prepared for another pandemic, because it takes into account not just what occurred during COVID-19, but also previous health crises, and could help us identify where we could improve as a country, as a unified health system, and as a profession. We spoke briefly about health data, and I believe that's critically important. Canada lacks on interoperability in many different ways, and we have the challenges in planning our workforce supply without adequate demographic, service activity, and geographical information. And that is, that's the reality of the system we're in right now. We need to work better together.
Thank you. And I noticed that the UK and some other countries have already started public independent inquiries. And the British Medical Journal also outlines several reasons why an independent national COVID-19 inquiry is needed in Canada, with accountability for implementation of recommendations. They listed some of these as failing to look to the past will ensure an unchanged future. Lacking an independent federal inquiry allows others to step into the frame. It would provide an actionable framework for reforming Canada's healthcare and public health systems, which were struggling pre-pandemic, as you pointed out. And it would ensure accountability for losses that included 53,000 direct deaths in Canada. Do you agree with the arguments outlined in the British Medical Journal, and would you endorse the call for an independent national COVID-19 inquiry for these reasons?
I think I would approach that by saying an advisory committee and a subsequent report would serve as a tool to consider what needs to be done immediately to help our healthcare system to recover. The Canadian Medical Association believes that health leaders will need to find efficiencies and employ strategies to optimize our capacity, virtual care, patient prioritization to clear the backlog in procedures. But we also know that decisive action needs to be taken to address workforce shortages, particularly nurses, and ensure that our health system is operating efficiently. These are immediate and urgent needs that we have to address our healthcare system.
World Animal Protection. In your submission as committee, you wrote the following. World Animal Protection supports Bill C-293 because it takes a One Health approach to pandemic prevention, requiring government to address the underlying causes of pandemics. What is the One Health approach, and how does it relate to both animal protection and pandemic prevention?
Through you, Mr. Chair. One Health is the intersection of animal health and welfare and the health of the planet and the health and well-being of people. I think the way that animals are stressed in the wildlife trade and wildlife markets, intensive farming practices that necessitate the use of prophylactic antibiotics are all examples of how animal welfare can be the solution to reducing disease risks.
Thank you. You also wrote that in an open letter to the WHO published in The Lancet, over 200 medical and scientific experts identified industrial animal agriculture as a significant pandemic threat and major contributor to antibiotic resistance. You touched on that. Can you expand on the role of animal health and welfare in preventing the emergence of zoonotic diseases?
you, Mr. Chair. Absolutely. We just completed a review, a literature review of animal welfare solutions to reducing prophylactic antibiotics. This includes everything from reducing animal density to reducing the mixing of unfamiliar animals, improving ventilation, sanitation, environmental enrichment, and increasing amount of the time before animals are weaned and separated from their mother. All of these are solutions to reduce the use of antibiotics given prophylactically, which is routinely done in Canada and around the world, and the reason why 75% of antibiotics are given to farm animals today.
So turning to wild animals, you point out in your submission that more than 1.8 million wild animals were imported into Canada between 2014 and 2019, and 93% were seemingly not subject to any permits or pathogen screening. Has the importation of wild animals led to the introduction of disease to domestic animal populations in Canada or provided any threat to human health?
I don't know if there are any direct links that I'm aware of, but it's certainly possible. The most well-known link is citrus fungus that's actually affecting our native populations. For farm animals, we do import mink, for example, which has been played a huge role during COVID in the spread and amplification of the disease. So the importation of wild animals, which is currently pretty unregulated and unmonitored, definitely poses a disease risk.
Can you tell us what the current state of knowledge is or theory about the source of the emergence of COVID-19? Is it still thought that it emerged from a zoonotic source, or what can you share with us?
Ms. Amers, I'll have to interrupt you. The time is up. I'll ask you to submit, at least suggest that you submit that answer in writing. Thank you very much. Thank you all. We're moving into our second round of questioning now. Dr. Kitchen, you have the floor for 5 minutes.
Thank you, Mr. Chair, and thank you for your witnesses. Dr. Taillon, your comments were very enlightening. You know, when we look at the act that is being proposed, in part 2, it talks about the purpose of the act is to prevent the risk of and prepare for future pandemics, and then the function of the committee that it's trying to structure. The function of the advisory committee is to make recommendations for the improvement throughout Canada of preparedness efforts and response capabilities in relation to disease outbreaks in order to reduce the risks associated with future pandemics. Now, I'm sure you Dr. Taillon, you're well aware that the Public Health Agency of Canada was structured after 2004, after the SARS epidemic, and to do basically exactly what I've just quoted. In fact, when we look at the Public Health Agency's function, its function is to basically to provide health promotion, health surveillance, health protection, population assessment, emergency preparedness responses, are also focused on preventing diseases and injuries, responding to public health threats, promoting good physical and mental health, and providing information to support informed decision-making. So not only are they doing that, they are doing it with a budget of, in 2022-2023, which was $7,439,195,456 just for infectious disease prevention and control, not to mention the $404,242,000 for health promotion and chronic disease preventions. So my question to you is, if all of this is in place with the Public Health Agency of Canada to do what this bill is proposing, do you feel that this bill supports, or do we need to get rid of the Public Health Agency of Canada?
Bien, chose certaine.
Well, obviously, Mr. Chair, we must remember, as the MP has said, there is already money invested in that. The mission is already clearly defined. So if the bill only reproduces the mission, just stating it in other words, then it's unnecessary. Otherwise, we have to look at it as a bill that is trying to deviate our attention rather than doing the real assessment of everything that happened, the mistakes, some shortcomings. during the last crisis. That's normal. No government is perfect. No administration is perfect. Otherwise, it means we're legislating just to grant new powers, adding some more coercive powers. That's what worries me. It's this coercion, the powers of coercion. This is aimed at the provinces. They will be forced into harmonizing their practices, whereas they should be allowed to innovate freely and implement their knowledge as close to their communities as possible, and also putting them in some system of accountability. This would be a way of subjugating them. They are not to be subordinate. And finally, trying to intervene too much in areas that stray from their mission. The federal agency is not following its mandate. They have to refocus on what is at the very heart of the federal jurisdiction, the issue of supplies and strategic reserves. That is the federal role.
You off at just short of time. Sir, the minister, Patty Hajdu, said in April of 2021, we are open to an inquiry that is deep as necessary. Minister Duclos said that in response to a question that he's confirmed that the federal government will still means to pursue some kind of review eventually. Do you consider this basically similar to, or would you consider this similar to basically a national pandemic review?
In 10 seconds or less, sir.
Il faudrait surtout.
We mostly require a review and inquiry on how the federal government exercised their jurisdiction. And unfortunately, I believe this bill is more of a diversion, and they're trying to get away from the need to do that investigation. They're leading us down other paths, trying to repeat things that are already in place.
Tayon, that's time. Colleagues, we'll turn now to Dr. Pawlowski. You have the floor for 5 minutes, please.
I think I'll start by addressing this question to Dr. Barrett. Dr. Barrett, if you look at the recent pandemics, COVID started in Wuhan, HIV/AIDS, I think, which would classify as a pandemic, started, we believe, I think, in Africa. H1N1, where was it, China or Mexico? I'm not sure really if we know for sure. The other outbreaks that we were kind of worried would become pandemics, like MERS was Middle East, Ebola was in West Africa, SARS is in Guangdong, China. When we're looking at how we can better prepare to prevent future pandemics, would you agree that we need to globally be better in poor countries also at early on detecting outbreaks of disease and responding to them quicker before they become pandemics?
So two pieces to that. I think that if there's one thing that we've reinforced for the general public, governments, and for medical practitioners, among other people, it's that the planet's very small. Unfortunately, very diverse in terms of resources. And to your point, yes, we do need to have and support for countries that are still in a developing state more resource to be able to do effective and directed surveillance of what's happening in their countries. But to be frank, I think it's important to also note, coming back to some of the comments earlier about, taking away the ability or power for people to be autonomous as entities, whether that's a country or a province. No one is suggesting that people shouldn't have autonomy, but that there be base standards and science used to determine what base standards are. And it would be useful and helpful for a bill like this to provide both direction around capacity building for global surveillance, but also to set some standards for what the science would suggest is a base standard. So I guess also not just generating the data, but sharing it and using it in a way that generates base equivalence so that people don't come from have and have not states, provinces, or countries as humans.
Okay, so thank you, Dr. Barrett. So it seems you agree that we have to do, or we want to, both as a country and globally, do better in poor countries at being able to detect and respond early on to outbreaks of infectious disease. So I've talked to Nate, the sponsor of the bill, about adding language to this bill which would ensure that Canada explores international legal agreements and including in those negotiations, considering in those legal instruments financial mechanisms, including potentially mandatory financial mechanisms, which would ensure rich countries provide under-resourced countries some of the funds that they need in order to better detect and respond to infectious disease. So should that be one of the things that Canada is obligated to do to, because that's what we're looking at in this bill, to enter negotiations with other countries in terms of how we can help poor countries have the capacity to detect and respond to outbreaks earlier?
The mechanism for doing that is certainly beyond my scope of expertise. To say that it's absolutely needed and to be deliberate about wording in a bill that makes us an excellent global partner, I think is very important, and understanding that those would be durable and practically implementable would be important. The how of that, I'll leave to people who do this for a living. I'm absolutely sure that's not me, but the need for that is definitely present, and the need to be building and guiding science globally.
Kathleen, do you want to just, in a brief time, respond to any of that?
No, I would agree. And the CMA does recognize the equitable global access, particularly to vaccines, as a valuable public health tool. Again, the where and how that gets implemented is outside of the scope of recommendation for the CMA, but certainly ensuring that we are meeting our requirements as far as human rights obligations. I believe that's well within this bill. Recognizing and understanding alongside this is that access to basic primary care services around the world is lacking, and investing in primary care is investment in preventative care and getting to patients before they get sick and resorting to either overburdened emergency departments or are not able to seek care before they infect others. These are critical pieces.
Thank you very much, Dr. Ross. Thank you, Dr. Pawlowski. Colleagues, seeing the clock and looking at the calculations we have done, I'll just be clear. Michel Thériault, you will have 2.5 minutes. Mr. Davies, 2.5 minutes. Mr. Majumdar, 5 minutes. And Dr. Hanley will finish with you for 5 minutes. Michel Thériault, vous avez la parole pour 2 minutes et demie.
When we talk of animal protection, in a memo that the Quebec chicken farmers sent us, they criticize this bill C-293. They say they're trying to prevent pandemics and to make sure that their content is not only about preparing this, but there is some negative perspective in terms of animal raising. The concern for the producers on this is the language used to describe major industries. Stress is put on agriculture in terms of resistance to antimicrobials instead of using a single health style. So later on, they talk about their plans and strategies on responsible use of antimicrobials in link with their strategy on responsible use of antimicrobials approved by the Health Canada Veterinary Medicine Department. What do you think of these different criticisms of the bill?
If I understood correctly through you, Mr. Chair, the question is, there are criticisms for what do we think of criticisms from farmers that are concerned about the language used with respect to antibiotics? Well, I think, I can sympathize with farmers who are concerned about the stresses they face and the challenges they face producing food for our country. But I think the science is clear, and this is a pile of reports that cite the drivers of pandemic risk. And I think we need to be listening to the experts on this and looking for solutions so that we can save antibiotics and protect them, life-saving drugs for people and for animals. And I think it's a challenge that we need to, it's one of the biggest health crises that we're going to face. It's the silent pandemic.
Mais eux, ce qu'ils disent, c'est...
But what they say is that currently the strategy on responsible use of antimicrobials from the chicken farmers of Canada is based on key elements such as research and innovation, surveillance, to meet the needs of the consumers and also to protect the health and of the birds. So, do you agree with them or not? Thank you, Mr. Therio.
If you, I suggest that you provide a message in writing, please. Thank you. Mr. Davies, you have the floor for 2.5 minutes.
Thank you. To World Animal Protection, your submission states the following. The Netherlands has expedited a permanent ban on fur farming to prevent further COVID-19 outbreaks, and the German federal parliament has agreed to reduce the trade in wild animals for pets, ban the sale of wild-caught animals, and set up a centralized trade register. Would you suggest Canada act in a similar fashion, and if so, why?
Absolutely. Currently, there is very poor data collection on which wild animals are coming in. We don't know the history, and there's very little biosecurity at the border. So we need a comprehensive, detailed data set to be able to analyze what risks, like what animals are coming in, what are the risks, what is their life history, are they wild caught, and what kind of biosecurity risks do they bring with them. At the moment, we don't have this. All departments are siloed. They all have a different piece of the puzzle, and it's acknowledged. We had a meeting earlier today where they need a more holistic mandate to approach this issue, because we're talking about an enormous trade that is happening and an enormous number of animals coming into our country which we're not monitoring.
And finally, how does climate change and loss of biodiversity increase the risk of pandemics?
So when animals are stressed, whether it's in captive conditions or in the wild, where their habitats are, when we encroach on their habitats, animals are being forced to interact with each other that might not have happened before. They might have been, they become in situations where the disease pressures are rising, and they come more in contact with people, and that's where that interface happens. So when we don't protect their natural habitats, when we encroach on it, it increases the risk of pandemics and of zoonotic disease emergence and the spread of them.
Thank you. I anticipate the chair can tell me I have very little seconds. Just Dr. Barrett, do you think that we should have an independent national inquiry searching to get at the bottom and learn lessons from the way we handle COVID-19?
I think there's already probably some mechanisms to do that within the organizations that exist, but should there be a review of what has happened from a comprehensive perspective that focuses on a go-forward plan as opposed to a blame game? I would love to see that happen. I think there have been many successes and many challenges along the way. And we're coming into a time where everyone's fatigued and trying to ignore the fact that we still have risks. And it's a really difficult behavioral time for people. And I think a very well done review and constructive process forward would be very helpful.
Thank you, Mr. Davies. Thank you, Dr. Barrett. Last 2 rounds of questions. Mr. Majumdar, you have the floor for 5 minutes.
Thank you very much. You know, at the onset of the pandemic, the Trudeau government discovered that it had dismantled a critical and successful early warning system. When the world began border closures to protect citizens, Health Minister, do as I say, not as I do, held to ideology, decrying conspiracy theories, accusing critics of racism, parroting the People's Republic of China talking points, and outsourcing critical national interest decisions to a World Health Organization bent on destroying its own credibility. This Bill C-293 is not a pandemic inquiry. it barely begins to assess pandemic prevention. And it begs that we pay better attention to what decisions were made in that time. Dr. Barrett, in the past, you stated you're a fan of keeping masks on faces and defended mandates on social media. Let's see how that played out. The Alberta Medical Association survey cites 77% of parents reported that the mental health of their child aged 15 and over is worse than before the COVID-19 pandemic. And according to the Canadian Institute for Health Information, during the first year of the pandemic, almost 25% of hospitalizations for children and youth were mental health related. Let me ask, these mandates destroyed the mental health of Albertans and Canadians, destroyed small businesses, and destroyed livelihoods of thousands of people who are now afflicted by an opioid crisis. Do you still stand by your comments today?
Not directly exactly related to the bill, but happy to take the rhetoric and start with a response to the question that I think was there. And address a little bit of the leap of logic in the middle. There are just as many studies that suggest that in certain settings and during certain points in the pandemic, that masks were valuable at community levels, and particularly not just for children, but for people in very vulnerable situations. So yes, the recommendations that I was making, and including now in acute care settings where there are vulnerable persons who are still vulnerable, I would definitely defend. I don't know that I needed to defend it. Do I think the science supports continued masking in certain situations to prevent airborne and or droplet-borne disease prevention? I do. And just to step back for a moment and address your gap between mental health and the pandemic being associated fully with masks, that clearly is a mistake because there were a myriad of things that developed many mental health issues, regardless if people lived in countries, provinces, or areas where masks were mandated or not. That's a multifactorial issue, but I do appreciate you asking the question.
Thank you for your response. I mean, for children between the ages of 6 and 14, 70% of parents reported that their children's health was worse off than before the pandemic. A large portion of this is cited due to the lost access to natural outlets for stress and anxiety, such as sports and after-school activities due to these restrictions. During the COVID-19 pandemic, the Toronto Star featured angry quotes about the unvaccinated on the front page on August 26, 2021, including the bold sentence, "I have no empathy left for the willfully unvaccinated, let them die." Justin Trudeau added to the divisive rhetoric, "They don't believe in science or progress and are very often misogynistic and racist." This leads us as a leader and a country to make a choice. Do we tolerate these people? Dr. Barrett, do you agree with those sentiments?
So again, not specifically about the bill, but I could link it to the bill. I think that having pieces of misinformation, disinformation out there like that, particularly around vaccination, is part of the issue. And if this bill can actually develop a process where science is promoted, as well as the dissemination of science in a trustful way, we could probably get rid of a lot of those statements. So those are not statements that I would support. And I think it's a demonstration of overt mis and disinformation from certain individuals. So hopefully we can get beyond that. And maybe there's some use for a bill like this to promote it.
You know, I'm stunned that the evolution of thinking has not taken place given the impact of what decisions were made during the pandemic. I mean, were the lockdowns valuable, Dr. Barrett? Mandates that force businesses to only have a few customers in at a time. Do you really think this is an effective pandemic approach?
Dr. Barrett, unfortunately, we are out of time, and I would, again, as I've suggested other times, that you could provide that in writing. Thank you very much. Thank you, Mr. Majumdar. And colleagues, for the final 5 minutes of questioning, we will turn to Dr. Hanley. Dr. Hanley, you have the floor.
Thank you, and thank you to all of the witnesses for being here, and also for your patience this evening as we get towards the end of this really interesting testimony. Dr. Barrett, I'm going to stay with you for a while. Towards the end of your 5-minute talk, you had just started to touch on the need for vaccine studies, post-market vaccine studies, to better understand immunity. for pandemic pathogens, and thinking of, again, how are we looking forward? How are we preparing for the next? I just wondered if you could elaborate somewhat on that issue of what we need in terms of federal support and how this might relate to this bill.
Yeah, thanks for the question. So if we're trying to build a situation of preparedness, obviously vaccines are a key and core part of that, particularly for illnesses of pandemic potential. When we currently are licensing very safe vaccines in Canada, which we know we do, the part that we often forget about is that we have great vaccines, but we can always expect and raise the bar and make them better. And one way to do that is to have people involved in the manufacture and dissemination of our vaccines provide us with studies around immunity and effectiveness in real time and real immunity. And that's really important for us to go forward in building a real science base that adds trust in vaccines, ups the ante, not just 80%, but 90% or 100% effective, and understands what people need at an individual level. And we can do that potentially through a regulatory way, especially if we demand that in our pandemic preparedness plan and prevention plan, vaccines be maximally effective, licensed and subsequently modified as we go along. So rapid access, but high standards for modification afterwards.
You mentioned trust there, and I wanted to, again, maybe take you up on that a bit more. Despite the incredible success of the vaccine strategy and the other, combined with the other application of public health strategies, we know that there was loss of trust in our population, and that's kind of an enduring phenomenon that we're seeing that's spilled over into other areas. How? I guess how, again, as we look at reviewing what we did with a view to looking forward, what are the key elements to rebuild trust? If you could give me a 20 or 30-second answer, then maybe I'll have time to switch over to Dr. Ross. Thanks.
I'll be swift. I am not a trust-building expert. However, I do think that very effective, directed, and transparent communications and decision-making are key. I think we've fallen a little bit into a situation where we often strategize too hard and worry too much about what we should or shouldn't say sometimes. And I think that timely, transparent communication doesn't always have to be the same message, but just transparency around decisions and how they're made and why they're going to change would have been very helpful and will be helpful going forward, I think.
Dr. Ross, really good to see you, and thanks for your advocacy. You again referred to the depleted workforce, and you know, when I think of how we match that to the fact that we are in a pandemic era, that we are not necessarily insulated from another pandemic just because we are still recovering from a recent one. So I wonder if you're looking ahead with some urgency to preparing and at the same time restoring our workforce. Could you give one or two most critical elements of being prepared for the next one? I think we have about 40 seconds left.
Thank you. I'll try and be very, very quick through the chair. PPE and vaccinations certainly made a huge difference in the pandemic. And as far as trust and trust building goes, we know the most likely predictor of encouraging vaccine hesitant people to get their vaccine was actually attachment to primary care. As I look forward, I think Canada needs to have a hard look, and I hope the advisory committee would do that, as to homegrown PPE, vaccines, medications, sustainable access to respirators, IV pumps, epidural catheters, all of those things that make our work as frontline healthcare providers possible. Having a close look at, the impact of the basic income funding that came across and looking at social housing to support behaviors in self-isolation. These are all things that would support the work that we do as frontline healthcare providers.
Thank you very much, Dr. Hanley, and thank you, Dr. Ross. It was a good try, Dr. Hanley, but no, unfortunately, we're out of time. Colleagues, I want to thank the witnesses for taking the time to appear today and for sharing such valuable information. I do understand that you probably had better things to do than listen to committee business, but I do thank you for your patience.
Point of order, Mr. Chair.
for being here.
I'm just wondering if, I mean, we lost a lot of time with witnesses, if we could have if we could have agreement
Mr.
of the
Davies,
committee
excuse me,
to
sir.
extend the meeting by
Mr.
15
Davies,
minutes.
excuse me.
Yeah.
Please wait to be recognized by the chair, if you would, if we're going to have some decorum
There's a
here.
point of order, Mr. Chair.
Yes, I understand that. I do believe that Mr. Hanley had his hand up first, so thank you. Dr. Hanley.
Fortunately, on a similar theme, Mr. Chair, my point of order was to, given that we have a stellar lineup of witnesses and did lose some time at the beginning, I wondered if the committee might indulge at least another round of questions to get the most out of this session.
I will confer with the clerk and understand if we have more time. Thank you. Thank you, colleagues, for that. So I do understand that we have another 15 minutes of time available for translation. If it's the will of the committee, obviously we have time for one 5-minute round each from the Conservatives and Liberals, and 2.5 minutes each from the NDP and the Bloc Québécois. Is it the will of the committee?
Monsieur le Président, question, faudrait peut-être.
Question maybe we should ask the witnesses out of politeness if they also would like to stay. I think that would be the right thing to do.
Point, Mr. Thériault, thank you for that. In deference to our witnesses, if you have 15 more minutes, please perhaps indicate to me a little wave, a hand up, thumbs up, something. If you're willing to stay, excellent. So we have the will, so we do have the time. Excellent. So as I said previously, we will now have 5, 2.5, 2.5. We'll begin with the Conservatives, and we'll begin with Dr. Kitchen. Dr. Kitchen, you have the floor.
Thank you, Mr. Chair, and I appreciate that opportunity. And again, thank you to the witnesses for staying a little extra for us. As I'm sure you're well aware, the BMJ has published a number of articles on Canada's response to the virus. And one of the quotes that I will read to you from it basically is stating that a national inquiry in 2023 is crucial. Consistent with reports both before and after this pandemic, we call for a culture of data sharing that enables diverse use from a broader range of users. My question, I guess, will start off with to you, Mr. Talion. Do you feel this is a national inquiry, or sorry, I apologize, Dr. Talion. Do you feel that this is a national inquiry that the 283 will provide?
No, I don't think it's an inquiry. It's forward-looking, BC 293, and unfortunately, I think it's a diversionary tactic. They don't want to do the analysis that is required. I think each administration has to do an assessment. I think the agency could draw certain lessons from the experiences from recent years, but unfortunately, I worry that trying to anticipate or project a future crisis, we don't do the necessary analysis. So, to answer your question, why was the federal government so slow in managing the crisis at the border, lifting some of the quarantines? Why was it so hard to manage the vaccine supplies? These are issues that the federal government has direct jurisdiction over, and those issues should be the priority.
Dr. Ross, you talked a little bit about database collection, and as I just read from the article from the BMJ, and the fact that we weren't seeing the data sharing, And you know, when I was on the Health Committee in 2020, when this first came about, that was a lot of what we heard from the researchers. Throughout was continuously, there's no data sharing. There are silos that are being created, and those silos are keeping that data internally as opposed to sharing. And I guess my thought is, and I know you believe that we need to share that data. It's very important across this country to do that. From what the report says, it basically, or sorry, the bill, it's dealing with addresses it, but does it provide enough information to allow for us to get that data sharing and breaking down those silos?
So I'm a huge fan of breaking down what I like to call cylinders of excellence instead of silos. I think we have to have data sharing and ability to share data across jurisdictions, even from community into acute, so that we can actually get to that practical research that's timely and can inform the needs of public health and public health service delivery. I think the fragmentation of data that we have, the lack of interoperability, even sometimes across the street, unable to access data for our patients, harms patients, and access to data and interoperability will in fact save lives.
Thank you for that. One of the 5 of the things that were reasons that were brought up in the about an independent national inquiry were to basically, it's tough for me. Sorry, I only have a minute to read, so I won't be able to do it. But the reality is that having that independent national inquiry is such an important thing that Canadians have been asking for. The ministers have said that they will provide, and we need to do that. And our concern is that this report is going to be substituted for that national inquiry. And I'm wondering if you would agree with that.
I think no matter which route this committee decides to proceed with, we have to look forward. There are lessons that we definitely can learn from how the pandemic unfolded. There's zero question that this was an unprecedented in our lifetime event, and we do need to look forward to prepare for the next and learn from our lessons in the past.
Thank you very much, Dr. Kitchen. Thank you, Dr. Ross. We'll now turn to Dr. Pawlowski, and I understand you'll split your time with Dr. Hanley. Is this true? Great. I'll turn the floor, with Mr. Fisher. Dr. Pawlowski, you have the floor.
To the witnesses, I think I look at this act, and it's actually fairly simple, and I think Nate himself has agreed that in terms of the review of the pandemic, he's not all that keen about on that part, but he certainly wants the second part, which is basically, I think, setting up or requiring the government to make a pandemic preparedness plan, and for various ministers to have certain things they have to do as part of that pandemic preparedness plan. And 2 years after the act comes into force, that plan has to be tabled in the House of Commons where it's public. We and everyone can review that plan, and then every 2 years afterwards, the plan has to be updated and reviewed and again presented to the House of Commons. So not only us, but the opposition gets a chance to review that plan again and to comment on it. So 2 questions to Dr. Ross and Dr. Barrett. Is that generally a desirable thing? I would have thought it is. We saw in terms of the COVID pandemic that there were certainly a lot of questions as to what the plan was. Was there a plan? And I would have thought this is a very desirable thing to begin with. And do you have any specific things which you would like to see as a requirement for the minister to include as part of those plans? So maybe I could start with Dr. Ross and then Dr. Barrett. Thanks.
Thank you very much, and I'll be brief. The CMA has been very active in pushing for transparent accountability with regards to the healthcare system in Canada, not just looking back at the pandemic and being prepared, but actually moving forward so that the citizens of Canada can understand where investments are being made and what outcomes can come from that. So I would be in favor of ongoing accountability measures.
Dr. Barrett, and you have to leave yourself a minute because somebody else wants to ask you a question specifically.
So yes, having a plan is a good idea, not a shocker there. And yes, a pandemic plan would be delightful. No doubt about that. And also, you might want to beef up the science-y bit and the accountability to science and not suppressing it, using it as not just guidance, but the anchor. So that's my answer.
Darren, pardon me. I'll give it to you.
Thank you very much. Dr. Barrett, I know it's late at night in Nova Scotia. You're closing in at 11 o'clock, and I'm sure you have a very, very busy day. But I wanted to thank you on behalf of Canadians for the care and the compassion and your tone. You were the face of COVID, at least in Nova Scotia and in Atlantic Canada, but your knowledge and your care and your compassion were evident every day in people's homes on TV. And you had the best backdrop of COVID. I'm interested in your key takeaway. I think the key takeaway is the need for data and the ability to use data, but I'm interested in your key takeaway as part of future preparedness.
It's raised the bar. We've been far too lax for far too long about data, about health, and what we expect from health prevention. And now is the time to up the bar and expect more. And we're going to have to do that through science, both data generation and connectivity. That's what I think we need to do. And I hope that this would be a beginning step towards that in this bill.
Thank you very much, Mr. Fisher. Thank you, Dr. Barrett. We'll now turn to Monsieur Thériault. Vous avez la parole pour 2 minutes et demie. Merci beaucoup.
Oui, 2 minutes.
Yes, 2.5 minutes, I have, you say. Without having to look for guilty parties, there were 3 colleagues here that sat in the Health Committee. They sat throughout the pandemic, and we're one of the few committees that were sitting all the time. We had 3 colleagues that lived through the pandemic within the committee, and I'm not trying to look for guilty parties. We're finding solutions. I think this bill puts the cart before the horse. We must, first of all, do an analysis, know exactly what happened before trying to come up with solutions. For example, how can we explain that the World Information Network for Public Health could have been so ineffective and not raised warning signs early? And we were sending supplies to other countries such as China, whereas we're running out. And there were consequences in that, the fact that we did not have sufficient masks in our Quebec health centers. So I think it's important to find an answer to this question. I don't think an advisory board could go in depth on that. So I'm not pointing fingers. We have to first find out what we did, what we could do better, and come up with an action plan. I don't think it's a bill that would solve the problem. I just want to hear what you have to say about that. Dr. Barrett.
I think critical and root cause analysis would be part of whatever this group is going to do, and it's the look forward. This is the 3rd time it's been said by 2 different people. The look forward, far more important than, to your point, the blamey bits. I think that, a lot of what you mentioned will come up already, and that's pandemic preparedness within our domestic group, and that means PPE generation. It means vaccine development and bringing up to author.
If that group is not independent, do you really think that they can have the flexibility to look really in depth? Like I say, we are not trying to accuse people, at least the 3 colleagues that went through the pandemic. That's why this is not normal in 2023. I don't understand why it's 2023 and we haven't really gone into that analysis.
Mr. Thériault, well, if you could tell us who that was directed to, then I might be able to suggest they provide an answer in writing.
Oui, ben, toujours.
Yes, it's still addressed to Dr. Barrett.
Mr. Davies, you have the floor for 2.5 minutes.
Dr. Ross, I noticed from your biography that you were a founding member of Doctors of BC's Diversity and Inclusion Advisory Group. and you're also were physician lead for the Royal Columbian Hospital's Anti-Racism and Unconscious Bias Working Group. It says that in those roles you were committed to fostering learning, awareness, education, and ongoing implementation of inclusive, diverse, and anti-racist practices in healthcare. So I put this next question in that context to you. The British Medical Journal, again in reporting on Canada's COVID-19 response, found that despite ostensibly universal health care, the highest rates of COVID cases and deaths in Canada were among people already disadvantaged or at special risk. These were racialized ethnic groups, migrant workers, essential service workers, and those living in crowded housing. For some Indigenous people in Canada living on reserves, the lack of access to basic needs such as clean water rendered early COVID hygiene advice impractical. In your view, do you agree with that finding, and what steps should the federal government take to ensure equitable protection for all residents in the event of a future pandemic?
So thank you for the excellent question, and through you, Mr. Chair. There's no question at all that we lack adequate data when it comes to race-based illness in this country. And I think that we've heard calls from many jurisdictions now to try and collect those areas so that we can identify and track health disparities and redeploy resources where they are most needed based on actual data. And I agree that the science and how we implement our measures is going to be critically important, but we don't know where to point our additional resources if we don't track the data to understand the problem in the first place.
Animal protection, what do we need to know? What's our advice?
I think what it comes down to, no matter how animals are being, if you keep a lot of animals in a small space that can engage in natural behaviors that are with unfamiliar other species, they're going to get sick. That's the bottom line. So we can't manufacture our way out of it with technology and such. Better welfare is the answer to better animal health, which is the answer to better people health. It's a very simple connection, and you know, we have all the evidence that needs to be addressed.
Thank you very much, Mr. Davies, and I will try once again. This time we are out of time, and I do want to thank the witnesses for staying later. And for those of you not in this time zone, obviously we thank you even more. And that being said, the information I hope was valuable to you all, and hopefully maybe you enjoyed the discourse we had beforehand. A bit of committee business, a reminder to members that the deadline to submit amendments for Bill C-293 is this coming Friday at noon. And on our next meeting on Monday, we'll be doing clause-by-clause consideration of this bill, Bill C-293. Thank you all for indulging the newness of this chairmanship to me. And also, I would like to, on behalf of this committee, wish our usual chair, Mr. Casey, Godspeed in what he is going through at the current time. Is it the will of the committee to adjourn? Yes. Yes, it is. Meeting adjourned.
Thank you.